Hi guys, welcome back to my channel. My name is Melissa Rodriguez for those of you that don't know me, and I'm a third-year medical student in Florida. For today's videos, as you can see by the title, I'm wanting to cover how to present patients for the surgery rotation specifically. I'll probably do another video on how to present for internal medicine because that's my favorite specialty, and you guys know it's totally different, the surgery service from the internal medicine, because it's more extensive, whereas in surgery, surgeons are really efficient and to the point, complete but to the point, and rounds only last for 1 hour, so per patient it's maximum of 2 minutes per patient presentation. And I feel like now, after 2 weeks in surgery, I finally feel comfortable doing my presentations every day and preparing them in an efficient manner. So this is what I'm going to teach you today. If you're interested in learning anything about this, if you're preparing for third year or preparing in general for any surgery rotation, please keep watching. Let's start with the first part. The first part of all of this is gathering the information, right? When you're in the surgery service, you're starting rounds at 6:30, which means you get into the hospital depending on how many patients you have. I try to get there by 5:30 so that I have 30 minutes to look at information in the computer and 30 minutes to go see the patients. You don't need as much time to go see the patients as you need in medicine, so that's why I leave myself like 30 minutes before rounds. If I gather this information in an organized manner, I should be ready to go. After seeing the patients, I should be ready to present them right away. So the first thing you need to have is a notebook. So I'll show you the notebook that I have been using. So it's full already. I already filled it out with patients, but it's basically something simple, something like this, right? With 2 pages, and you're gonna organize your notes based on how you're gonna present. So you're gonna use 2 pages per patient. Of course, put the name of the patient, the age, and the room number so that you know where to go. Now, the way you think about presentations is the SOAP form, right? The form that they teach you in medical school, which is subjective, objective information, assessment, and plan at the end. So that's the traditional way of organizing your presentation. But when it comes to different services, there's additional things that you need to add, that this is why it makes it a little bit difficult, and depending on the attending as well. So the first day that you're gonna go into the surgery rotation, it's good if you go and listen to how people are presenting, especially if other students are presenting. If they have a little bit more time in the rotation, you can listen to the recommendations from the attending that it's there for the day. And the same thing with you. You do your best for the first presentation, and you really listen to that feedback the first day and ask, how it could be done better, so that you know specifically how that attending works, because they sometimes like certain things to be said differently. And I'm gonna explain this further as I go through the different sessions of the presentation. But yeah, it's different based on the physician, especially for the surgery service. So the way that you kind of like do good in these presentations is by knowing the most about your patient, because you're gonna have 3 to 4 patients, and the rest of the team members, like the residents and the attendings, are going to have at least 10 patients to see. So if you are only charged of 2 or 3 in the surgery rotation and you've been to their surgeries, you're gonna have to know the most about that patient, and of course the pathophysiology or whatever medicine it's involved in their treatment. Okay, so I have prepared my little template that I write every morning, and I have it all in my brain. And as you do them more and more every day, you're going to just learn it by memory, and you're just gonna go to a blank page and just write it out for yourself. But this is for post-op. I'm gonna talk to you more about consult presentations later on, because those are faster. Those are not in the morning. The ones that we do in the morning for rounds, the rounds are basically, for the most part, the patients that we have operated on already, and they're post-op recovery. So this is how these presentations go. The ones for consult or when we're in the clinic with the surgeon, it's different. The rounds post-op presentations, you write the patient name, you write the age of the patient, you write the room number, right, of the patient, so you know where to go, and then you're gonna say post-op day number, and let's say post-op day number 1, status post the surgery that they had. Let's say it was a laparoscopic right hemicolectomy, 4, and you need to say 4. So let's say, what was it for? Was it for Crohn's disease? Was it because of a precancerous lesion that was unresectable on colonoscopy? Those things like that. So you need to say what it's that for, unless it's the surgeon that did the procedure that you're presenting to. You don't necessarily have to say all of that. But if it's a surgeon that did not do the procedure and this is a new patient for them, you need to say why they did the procedure. And then you say complicated by, and say the complications, if there was any complication in the procedure, or you can just say uncomplicated. And then you say the post-op course. Sometimes patients recover successfully and they don't have a post-op course, but some of them do. So this is really important for you to really shine, because you're gonna just let them know that you know what's going on. So let's say there was an acute hematoma, or there was a fever. So you will say complicated by post-op fever, or complicated by acute hematoma, or complicated by perforation of the colon during the operation. Hopefully that doesn't happen, but things like that, right? And then you say overnight. Overnight is basically what the patient tells you, how are they feeling. You go into the patient's room every day and you're asking them, how are you feeling? So this is what you're gonna write here. Did they sleep well? Did they feel uncomfortable with all the tubes and drains connected to them? What are they feeling, right? And then you say the pain. You ask the patient, how's the pain from 1 to 10 right now? And they tell you a number, right? And then you have to check in the computer, this is how you gather the information, which pain medications they're on. And you say whether it's controlled or uncontrolled in these pain medications. Most of the time they're taking narcotics like Dilaudid, hydromorphone, stuff like that, or they're taking Tylenol, Toradol. You need to say which pain medications they're on, okay? And of course you write here if they have any home medications that have been restarted, especially if they're like blood thinners or something like that that might be relevant. You write it in the med section of your little notes. Okay, so that's pain. Then you're gonna ask, are you eating or drinking? Sometimes they're not, and sometimes they have an NG tube. So if they have an NG tube, they're not eating, they're NPO. So you say patient's NPO and NG tube is in place. If they're eating or drinking, you say they ate, and you ask the patient, what did you eat yesterday? Because you wanna know the most, right? So you wanna know, are they just drinking soup, or, you know, having soft foods, or are they actually eating regular food? And then are you drinking? If they're not eating, are you drinking? Are you drinking water? Are you drinking juice? What are you drinking? And then you ask, are you experiencing any nausea or vomiting with this? This is important because if the patient vomited, they're not going in the right direction, right? When you are post-op, you are expected to have things moving down, not up. And you ask if there's burping as well, because burping is going up, right? So that's not good. Then you asked about voiding, or you check if they have a Foley in. If they have a Foley in, they're not gonna be voiding spontaneously. You just look at their Foley, and I'm gonna show you where you record the urine output, but it's not here. Here you just ask the patient, are you peeing? Are you having any difficulty peeing? If they are peeing spontaneously, if they don't have a Foley in, you ask, are you having any difficulty peeing? Next is passing gas or bowel movements. Most of the times, if they're post-op date 1, they're not gonna have a bowel movement yet, for the most part. That has been my experience. But you asked about gas. If they're having gas, that's good, right? If they're passing gas down there. But mostly, in order to discharge a patient, they should have at least 1 bowel movement, which means recovery of bowel function. Next is ambulation and SCD machine, which is sequential compression device. That's the little things that they put in their cuffs, and it presses, you know, it's like compression socks, but it works automatically. So if they have those on, and if they have been walking. So yeah, you ask about ambulation. Are they walking? How much are they walking? They will say yes. Then you ask how much. Did you do 2 laps, 3 laps, 10 laps? Are you walking in the hallway, or are you just walking in the room, right? And then of course I leave always a space in the bottom of this page to write a specific concerns. When you finish the patient interview, which is this part of the presentation, you ask them, do you have any specific questions or concerns that you want me to tell the surgeons or the doctors? And then this is where you will write them, okay? So that's for the subjective. This is what you present at the beginning, right? And I'm gonna give you an example of a presentation in a little bit, but I want you to see how I organize my information, how I gather the information in an efficient manner that will already help me present it once I'm ready for it, right? The next page, so you see this is the subjective information, whatever the patient tells me, and then here is the objective information page. Objective information is data that we gather from the computer. This is what we gather when we look at the computer before going to see the patient. So that's the vitals. Vitals are the most important. You get the vitals in the ranges. You get the ranges over 24 hours. You don't get just the last number, right? You want to know the range, because if there's like a extreme, like if they had a fever, you need to say, did they just have a fever on one measurement and then it recovered, or have they been having recurrent fevers throughout the night? Do they have a fever now, or did they have a fever yesterday afternoon and it recovered? For blood pressure, the same thing. You give the range, and if there's an abnormality, you tell them. For example, if they're on 90% on oxygen saturation, you need to tell them whether they're in room air or whether they are on oxygen supplementation. So for oxygen supplementation, you have to say how many liters on oxygen nasal cannula they are. Are they on BiPAP? Are they on the non-rebreather mask? What are they on? And that's what you have to always, when you go into a patient's room, look at the patient. Look if they have an NG tube. Look at the drainage from the NG tube. If they have a Foley, look at the Foley. Has it been emptied? Is it full? Is it bloody? What's the color of whatever they're draining, right? But that's for the next part. Next part, you say the vitals when you're presenting, and then you go to the physical exam. Physical exam is what you did to the patient, right? In general, in surgery, it was very surprising to me. They don't often do like a full-on physical exam. You present only the pertinent stuff, and of course you want to see if the patient is in acute distress. Listen to their heart, listen to their lungs. Some people don't present those findings, but I think it's still important to just at least mention regular rate and rhythm and clear to auscultation bilaterally in lung fields, right? And then you look at their abdomen, which for my service, I was in colorectal surgery, so that for that it has been the most important to say the abdomen is soft, non-tender, and non-distended, or appropriately tender, right? Because they're most likely gonna be tender after surgery, right? But you don't want them to be like dying whenever you put your hand on top of their abdomen. So you say appropriately tender, non-distended, or distended. Are they like looking at very bloated, very distended? That's not good, right? So you need to say that. And then you need to look at their wounds. For surgery, this is really, really important. Wound care is really important. They're gonna have multiple wounds for the most part. Look at their port sites and their main incisions. For laparoscopic procedures, most times we do 3 or 4 port site incisions, like really small 5mm excisions, and then we do a big one to get the organ out, and that one is most likely either a funnel steel, the wound that we do like for C-sections, which is like suprapubic, or a midline if they have to, or if they already had a surgery, they just got on the previous scar. So you look at those, you say clean, dry, and intact. This is what they care about, right? That it's clean, dry, and intact. It's covered by the dressing. You don't remove the dressing as a medical student, but you need to know if it has like erythema on the outside. You kind of like look at the wound. If it's warm, if it's red, if it's swollen, you need to tell them, right? If they get to the room and it's swollen like that, and you say that it's clean, dry, and intact, it's gonna look really bad, right? So you look at the wounds, and then you look at the extremities always, because we're looking for DVT after surgery. After surgery is kind of like putting the patient in a hypercoagulable state already, so it's important to look at the extremities for edema or pain, which will be concerning for a DVT or a clot, deep vein thrombosis in the legs. So if they have that, it's really important to report, and report if they have the compression devices, like I told you in the beginning. Now, next part you present is the ins and outs. Ins and outs is really important for surgery. You need to look at their ins, which is basically PO, are they eating and drinking? What has been reported is reported in the computer, but if it's not recorded, ask the patient, are you eating and drinking? So that you can say that it's not recorded, but the patient told you they ate, you know? So for ins, it's IV fluid, it's TPN. If they're not eating, they have like a total parenteral nutrition, in which they give them nutrition or basically food through their IVs. You need to report that as ins. That's something that went into the patient. If they're receiving IV fluids, you need to tell them which type of IV fluids and at what rate are they receiving it. If it's like the ringers, which is usually what they give, you need to say, are they at 60 cc's per hour? Are they at 100? Are they at 125? What is the rate that they're receiving, right? And then for out, it's basically urine, bowel movements, okay? Or NG tube drains, or if they have a drain like a JP drain, which is the one that they put you when they do liposuction, the drains that they put in your abdomen, they put that whenever they're concerned for hematoma or excessive amount of bleeding. So you need to record in the computer. They tells you how much did they drain overnight, okay? And urine output is one of the most important. They always record how much urine the patient is making in their Foley or spontaneously, okay? And that's gonna be really relevant to how they're doing. So if they have decreased urine output, that's concerning, right? If it's bloody, you need to just report how those draining fluids are looking like. Are there purulent? Are they bloody? Are they cloudy? Concerning for an infection and they like a UTI. So all of those are important, okay, for ins and out. And then is your assessment and plan. So here is the space that you leave for you to do at the very end. After you see the patient really quick, you have like 5 minutes, you write your assessment and plan. What do you think needs to be done today for this patient in order for them to go home? For the most part, post-op presentations and rounds is about recovery, right? How is this patient recovering? Do they need more time? Do they need their NG tube taken out because they already are good? Do they need their Foley taken out? Do they need their pain better controlled because they are experiencing really bad pain and their pain medications are not helping? Do they need wound care, more like advanced, like a vacuum, or do they need something else for their wound if it looks infected? Do they need chest x-ray because their lungs are not, sounding super well? I always check their lungs because atelectasis or collapse of the alveoli in the bottom of the lung, the bases, is really common with surgery. So I always check for the bases to hear if they're having, good airflow. That's really important. If they don't, say in the plan, I recommend a chest x-ray, right? Because I want to see if there's pleural effusions, if there's atelectasis, if there's pneumonia, especially if the patient's having fever, all of that. So it's many different things, but this is the holy grail of how you collect the information for you to have a smooth presentation, because everything is organized in the way that you're gonna say it to the doctor once you're in front of the patient's room, right? So let's give you a rundown through this. Let's go through an example, and then I will end this video and do a second one talking about consults in surgery. How do you present those before the patient has ever done surgery? Like, like someone coming with a new complaint to the surgeon's office, okay? But this one is more like post-op. So let's just give you a run through all of these. So you say, this is Mrs. Smith, a 54-year-old female, post-op day 1 from laparoscopic hemicolectomy, complicated by adhesions and excessive amount of bleeding. Post-op course hemoglobin dropped to 7 yesterday, but has been stable overnight. The patient slept well. Their pain is controlled, a 7 out of 10 right before receiving their dilaudid medication, not eating yet, but they're drinking some juice. They don't have any nausea or vomiting. They have a Foley in place. They're passing gas, not having bowel movements yet. They walked 1 lap yesterday night but didn't have a chance to do more. And they have the compressor devices on their legs. Patient has no specific concerns, just want to know how long it's gonna take for them to go home. Vitals, temperature is this, and this. Blood pressure is this. Heart rate is this. Oxygen saturation is this on room air. Ins and outs. Her IV fluids are like the ringers at a rate of 60 cc's per hour. PO 100. IV fluids 1,000. And then for out, urine output throughout the night 800, and over 24 hours 1,200. Physical exam, she is in no acute distress. Cardiovascular exam, regular rate and rhythm, clear to auscultation bilaterally. Abdomen is soft, non-tender, non-distended. Wounds, all 3 wounds are clean, dry, and intact, and the extremities show no edema. So for my assessment and plan, this is a 57-year-old female post of day 1 from laparoscopic hemicolectomy for Crohn's disease. Crohn's disease related stricture, and she is progressing as expected. So for her plan, I will continue pain regulation, take out the Foley for today, advance diet from soft to regular food, and see how she tolerates them. Yeah, that's it. So that will be an example of a presentation less than 2 minutes. And yeah, so with this, you're giving the physician everything that they need to know before entering the room in an efficient manner, and you're including everything that they need. So yeah, that's it for this video. I hope you really enjoyed it and find it helpful. I know I talk a little bit fast sometimes. Please put me in the slower mode in the speed if you need to, but I felt like this video was really important for me to share because I struggled a lot with presentations in the beginning of 3rd year, and I was, trying to organize everything in an efficient manner. For me, because presentations are one of the ways that we show that we are on top of things. So yeah, thank you so much for watching, and I'll see you in the next one.